Is that doing right?
Yeah.
Right. That's the only Norwegian I know other than the word skål. So I'm not too far from there, I guess. My name is Naveen. You all did a decent job of saying my name. I'll try it one more time. Naveen, last name is Bannur. Yes, I run SurgeryXchange. It's a platform that helps people with hospital discovery, price discovery of medical interventions. And it also helps people get medical second opinions. Now that's the company. And what I'm going to do today is more talk about opportunities in the Smart Health Program. And Mr. Ambassador, thank you very much for being here today. Yeah, and I need the... So, setting the context a little bit, we all know India is a big country. I think Ambassador mentioned it as well. Opportunities are always going to be very, very big. Even a small piece of Bangalore will be, half of Bangalore is more populated than Norway. So I think that's really setting the context. But everything around health is in the government, run by the Ministry of Health. The public spending in India is approximately 2.5%. That's what's set this year. In fact, last year was lower. You want to juxtapose that with what happens in a more developed country, a place like Norway is, somebody was saying, was 11%. US is around the 10% mark. So we're still struggling. Of course, like I said, it's a $2 trillion economy, which means that the numbers, the value itself is very big, but the per capita spend in India is very low when it comes to health from the government. Yeah? And also because the government has been a developing country, it largely focused on health and as a priority over healthcare. What it means is we're still dealing with programs to eradicate, and we actually have eradicated polio from India. We have eradicated tuberculosis almost from India. So the context is very different when you work with a country like India versus a more developed city. And as we go along, I'm not going to be doing so much smart cities, but more smart technologies around health. And like RP just said it right, we needed a lot more in non-cities and smaller towns than the cities itself. A little more, we have about one doctor for every 1,800 people, if you take the private sector included. But if you want to just look at the government doctors that are available, that's really, really bad. We're looking at one for every 20,000 people. So that's where we are. Huge divide in facilities with how the urban population is able to get medical care versus the ones in the rural markets. So, and when I'm saying this, I think what I want you to look at is the opportunity that each of these things are going to provide, are going to throw up for us in building equity in some form between these two markets for us to, using technology. Yeah? The market size for healthcare itself is about a $280 billion market. That's what we're saying it will be in less than 2 years. Yeah? And there's a huge internal demand. So there's a rural population that is now figuring out that they need to get better services. There's an urban population that's... Okay, we'd like to get people from outside India who can pay a little more for the same kind of services. So there's a huge medical tourism market in India as well that is growing every year. So this is really the disparity. So if you look at the large towns of Bangalore or Delhi, or Bangalore is where I come from, that's why I mentioned it. So this is how the differences would be. And today, more than 70% of the people live in rural markets, rural contexts. The average age is very, very low in India, and that's actually a good thing for us. And therefore, the spend can be a little lesser than other markets. But the life expectancy is actually growing. In the last 20 years, we've actually had people living 10 extra years than what they were living earlier. So that means that the geriatric care is going to come into play. That means people who are getting older will need more healthcare attention. The cost of insurance in India is very, very high. There is only now we're talking about government-paid insurance for certain sects of people below a certain income level. Yeah. And then less than 20% are actually covered by insurance. So most of them who are in urban markets, even in the urban setting, or 80% of them are paying for healthcare from their own money. So when there's a huge demand coming in from the urban markets and medical tourists versus the ones that are coming in from rural settings, there is a conflicting demand in each of these. So how is healthcare delivered in India? We have largely a government setup, which is functional, and I've used the colors basically to sort of signify where they are. And the PHCs, which is the primary healthcare centers in India, have been definitely not close to being good. The maternity centers specifically being made, which are not bad, and they're coming up better than where they were. The government is also doing secondary care and tertiary care in healthcare, and that's reasonably good, and not necessarily in terms of the quality of service, but in terms of quality of treatment, it's definitely green. The private hospitals, on the other hand, have therefore found this as an opportunity, right? And it's a big business in India. The entire 280 billion that you're talking about, most of it owned by the private hospitals. And there are different settings. There are private clinics, there are polyclinics, which means that they have a slightly bigger setup than a clinic, which is a practice, and they have certain basic tests that they can do there. And there's a secondary care, which can do certain types of medical interventions, and there are tertiary care hospitals, which are like world-class hospitals and world-class physicians in there. So who are the stakeholders? Government hospitals and private hospitals, already spoken about it. There is a private labs concept, which means that all of the testing and diagnostics about healthcare is done in private settings for people. And that's expensive, and it's not covered by insurance. And there are health insurers who are wanting to get into make the 20% look better, and they're coming up with schemes to have more people included in that setting. So there is because of the gap between the urban and the rural setting, the gap that is already becoming bigger, the technology players are coming in. The technology players are coming in to say, I can actually help you do several things sitting where you are. And that's where the e-health players, people like us, SurgeryXchange is coming in. And there's a huge, just go here. Still audible at the back? Yeah?
Let me give you the mic here so you don't have... maybe there is a battery issue. Okay, we will change that. Can you...
Oh yeah, of course.
Hold on. Yeah, so hello. Yeah, so the e-health and the medtech players are also coming in big time, and that's where there is a significant opportunity for everybody who wants to do something in the technology space. How does this work? So, to me, in the healthcare space in India, I'd like to classify, this is something that I've, in SurgeryXchange and anybody who's trying to get into the health space, I'm saying the three different classifications why you want to actually build technology products to service the market in India. And that's what I call the 3A paradigm. So there are issues of access, because there are people who live in markets or settings that can't get to towns where facilities are available. There's an issue of affordability, because there's inability to pay for the care. And then there's an issue of accountability, which is what people in the rural settings, in the urban settings are facing with, which means that you really need to now make sure that the quality of care is good and the effectiveness of that in terms of outcomes for medical treatment is good. So innovations are possible, according to me, in two different brackets. One, in the business process itself, and two, with tech innovations. And when you integrate them, that's really what the smart offering is. So let's look at the affordability quotient and how we've actually dealt with. The government has done a good job of actually bringing in insurance schemes for people below a certain income level. And that's done very well. People in the private hospital, and they can use that in private hospitals. So they're able to get certain kinds of things done. And for those that are very expensive, the hospitals are not really accepting those insurance because they don't really meet the cost parameters of the private hospital. Now, the other thing that you can do is platforms like ours, which is helping people to find hospitals or lower cost hospitals sitting where they are for the same kind of treatment. Yeah, and then the huge clutter of med tech products that are coming in. Yeah, and we'll see how some of those are actually coming in today. So this is a product on your screen that's built by one of the government organizations in India. It is an ECG device. You can actually build that for 400 NOx. So a very price sensitive market. There are several other things. What I've listed out there is only a fraction of the kind of technology innovation that is today prevalent in India. And most of these are done by startups. Most of these are done by startups. Of course, there are large organizations that are funding it, or they also have products. So I know a person who's building a product for detecting rotavirus. And it's a full-fledged research come product. They're actually taking it to market. And then there's a thing of accessibility, which is where the smart products have become very, very popular. She talked about telemedicine run by government. It's called SEHET. Actually is a product or a program for doing telemedicine, and it's working in decent levels in most places. It's marred by technology issues, largely from infrastructure. Then there are remote monitoring possible. This is where people are talking about Fitbits, wearable gadgets, and we're also talking about things like monitoring with service for things like sleep apnea, for example. So people now don't have to wear those big masks. If they have a problem with sleep apnea, they can actually wear a device that's on their hand, and that's really an oximeter, and there's somebody else who's monitoring when you're sleeping. So those are the other things that are also getting built. And there's something called a anytime health, which is like you just stick your hand in there and you get your vitals, versus going to a clinician. Like I mentioned, there are also others, which is in the e-health space, which is technology-driven largely, and those are directory services, finding where to get what kind of services in the medical space. Online opinions and doctor consultations online is becoming very, very popular. Yeah, and then there are AI-driven symptom checkers. Like I said, there is either a place where you can go and stick your hand, or there are symptom checkers that people are building. So this is the poor man's Watson. Yeah, and then finally the medtech itself. There's also a huge leap in the home care business from a healthcare standpoint. So what we're doing here, there are people who are we're talking about private labs. There are aggregation opportunities for labs. So where can I get a lab for a specific kind of diagnostic at a specific price? So there are aggregators there. And there are allied health service providers, which is those that are requiring nursing services, physiotherapy, and those who need there are the older population is getting bigger, therefore you need care is another example of how devices can actually. It's probably something that a lot of people in Oslo are talking about. And so the technologies that are here is a great opportunity to look at even in India. From an accountability standpoint, there are now ratings of hospitals, there are ratings for doctors and clinicians, and there is basic EHR in most places. But the larger hospitals are definitely investing in EHR and EMR. So I know that there are products in Norway that patient management systems, hospital MIs. So those are coming in as well. So talking about disparity, we now have ambulances which with the right telematics, so you're able to now start treatment even as a person gets into the ambulance. Remote ICU monitoring, the number of intensivists in India, not very big. So there's one intensivist taking care of multiple hospitals now with the remote ICU monitoring solutions that people have. A lot of technologies that are coming in for inpatient monitoring in nursing. So somebody who's got a sensor for putting. Yeah. So versus someone else, some caretaker who's with the patient had to actually rush to the nurse and say, now stop this. So those are the kind of innovations that are coming in. Huge focus on wellness, something that India was never into for a long time, is now coming in. Huge focus, corporates are diving in, employee services for things like wellness and nutrition is the other thing that's a big play. So my others did not want to talk about challenges, but and Torge is not here. I can speak a little more. I'm a marketer. He was not very happy with marketers. He's left, so I can probably speak a little more free. There are several challenges in a market like India. Where private hospitals are definitely using these systems, but they are not fully there. We are getting to a point with the government initiatives and a unique identity number for every Indian national. We are really getting there very fast. And there's an intent from the private operators to be able to actually have EHR EMR so that treatment can be better and they can be much more, deal with the effectiveness quotient much better. On the other side, the smaller and the mid-sized hospitals get patients who are apathetic. So they're not really, you're talking about data security, they don't care. Right? So they're completely fine giving up their data and they send it all on WhatsApp and everywhere else. So that's a different ball game altogether. And then it's, the doc, she was saying how bureaucrats could be eaten for breakfast. The doctors could be eaten for breakfast if the technology really thrives. So there's a definite defiance in the stakeholders to actually get the whole ball moving. But there will be a time when all these people have to come in and accept the situation, right? So penetration of telemedicine possible, but relatively slow in rural areas. It's extremely important that we look at those markets because that's where the big numbers are. The huge numbers are in these settings. And that's because of the lack of trust. People would rather go to the first and the second. They'd rather see a doctor. And in many of these places, technology is still an issue. They don't really have it. So we can talk about, somebody was talking about leapfrogging in Tanzania on how something did exist and they were able to do it. Same thing happened to us in telecom. Mobile phones were very easy. Same thing here, we didn't do too much in healthcare. Now for us to leapfrog in healthcare becomes easy. Having said that, most people have phones, they don't necessarily have smartphones. So intervention is still required. You need people on the ground who are able to help these people who don't have the access to technology or the ability to use technology well enough, but it's of definite feasibility. And startups are struggling to reach on their own. So most of these technologies are actually built by startups and they're finding it difficult to reach on their own. Other challenges in the IoT space, the affordability is an issue. So in the urban markets, you'll have people buying gadgets, they buy on their own. But when you go to the other markets, they almost want it free, if not at a very, very low price. Acceptance is slow, but we're getting there. Doctors are starting to use it. Examples of, like I said, sleep apnea is one of them. Diabetes monitoring, making sure blood sugar is all right at all times. These are being done by doctors themselves now. And then those are the kiosks. But what you have at the bottom is a potential user, so she wouldn't probably be able to use it. That's the challenge. So you need an intervention where somebody is coming in and helping people with the smart options. So what are the takeaway? There is a big play there. If you're a technology company looking to get into a market that can bring significant reach, it's a possibility. I mean, anything you build has to be around the 3A paradigm. And because these are markets that are very, very price sensitive, there's a huge opportunity for social enterprises in that space. So if anybody's looking at some products that are run on a social platform, great opportunity. And then rather than leaving the doctors and the stakeholders away, I think in version 2 of Smart Health in India and technologies, I think people will be looking at including them in the system to make it successful. Lastly, if you're doing anything in India in a startup, it's a marathon and not a sprint. So if you stay, you will not be sorry. Thank you very much.
Thanks a lot, Naveen, on behalf of all